Bismillah ar-Rahman ar-Rahim. Functional imaging of the breast, the future of breast imaging. When using any breast imaging modality, we say we have a benign lesion when lesions completely fulfill benign criteria, and we say we have a malignant lesion when lesions fulfill malignant criteria. But unfortunately, things are not always black and white as they appear to be, and we have a considerable number of lesions which fall in a gray zone, or what we call the indeterminate breast lesions. And when adding new technology to breast imaging, we are mainly aiming to increase the white and the black zone on the expense of decreasing the gray zone. And when looking at these breast imaging modalities, some of them attempt to decrease this gray zone through providing functional information, which is either through the injection of contrast media, like the contrast mammography and MRI, or through providing some information about the metabolic activities of the cells, like the PET mammography. And we'll start by discussing the modalities which provide functional information through the injection of contrast media. As the tumor cells multiply, they secrete pro-angiogenic factors that stimulate the proliferation of new blood vessels and new capillaries. But fortunately, these new blood vessels are not well formed, and they allow leakage of the contrast media within the tumor itself and within the surrounding parenchyma. Both modalities also have different features. Contrast mammography is less time consuming, better tolerated with a relatively lower cost. It is easier to interpret, and we can assess microcalcifications on the low energy image. But we have to admit that still MRI is the top-notch modality in breast imaging because of its multi-sequential and multi-planar imaging capabilities, which allow better lesion detection and characterization. They are both indicated in detection, or what we call screening, and when lesions are identified, they are indicated to characterize these lesions and to preoperatively stage these lesions, and they are also indicated in the follow-up of treated breast lesions. And we'll start by having a look at detection. In general, the female population is classified into an average risk population, a moderate risk population, which have an increased incidence of 15 to 20%, and a high risk population, which have an increased incidence of about 20 to 25, of more than 20 to 25%. For the average and the moderate risk individuals, mammography may be indicated as a screening modality starting the age of 40, and it might be complemented with an ultrasound examination. And for the high risk and the moderate risk individuals, again, mammography is indicated, but starting at an earlier age, and it might be complemented with an ultrasound examination. But in the high risk and selected moderate risk individuals, also MRI is indicated in addition to mammography. And it is here exactly where contrast mammography can compete, because why perform mammography alone and MRI alone when we can get the same information using a single modality, which is the contrast mammography? But up till now, there is no sufficient evidence in literature that contrast mammography can totally replace MRI, and it is used on recalling patients from screening programs and in the follow-up of some selected patients. This is a moderate risk individual. She had a heterogeneous dense breast parenchyma, and she was assigned a BI-RADS 0, and she was recalled for further investigations. Going back to her an ultrasound was indicated, and it revealed multiple speculated hypoechoic lesions. And actually, going back to her mammogram, we could only identify one of these lesions. So contrast mammography was indicated, and it revealed an underlying multicentric focal non-mass enhancement. Mastectomy was performed, and the surgical pathology came back with a multicentric invasive duct carcinoma grade 2. And now we move to diagnosis. To characterize breast lesions, we classify them into non-enhancing lesions and enhancing lesions. For the non-enhancing lesions, they are almost always benign, with a very few exceptions of malignant lesions which do not show contrast uptake, and these include some low-grade DCIS and invasive lobular carcinoma. And for the enhancing lesions, they are classified into malignant lesions, and we only have a few benign lesions also which show contrast uptake, and therefore to characterize enhancing breast lesions, we should follow the MRI morphology descriptors to be able to differentiate whether they are benign or malignant. This was a female patient. She had a palpable left breast mass lesion that has recently increased in size. This was the mammogram of her left breast, which showed two adjacent obscured mass lesions. An ultrasound was indicated, was requested, and it revealed one of these lesions was hypoechoic and the other was isoechoic, and there were pathological axillary lymph nodes. This was the contrast mammogram, and one of these lesions showed in contrast uptake, and the other one was non-enhancing. A biopsy was taken, and the non-enhancing lesion was a fibroadenoma, and the enhancing one was an invasive duct carcinoma. For local staging, we should describe the size of the lesion, the number of lesions, the extension of the lesions, and the lymph node status. This was a 49-year-old female presenting with a palpable left breast lower inner quadrant mass lesion. She had this lesion, which appeared irregular, indistinct, and it was hyperdense as compared to the surrounding parenchyma. This was the contrast mammogram of the same patient, which revealed another lesion in the retroareolar region. It was also irregular, non-circumscribed, and it showed intense contrast uptake. This was the MRI of the same patient, showing exactly the same findings like the contrast mammography. This was another case. She had a left paraareolar malignant mass lesion that was apparently infiltrating the nipple. This was the contrast mammogram of the patient, and the lesion on the contrast mammography appeared smaller than it appeared on the mammogram. But unfortunately, there was another lesion in the upper outer quadrant of the left breast, and this was the MRI of the same patient. And again, the surgical pathology came back with a multicentric invasive duct carcinoma. And lastly, we go to the follow-up of patients. This is a 37-year-old lactating female with a palpable left upper outer quadrant mass lesion, which was previously misinterpreted as a fibroadenoma, but it is not accepted to say that it is a fibroadenoma with this increased vascularity. This was the low-energy image of the contrast mammogram showing a focal asymmetry in the left breast, and this was the contrast images which showed intense contrast uptake. Biopsy was taken, and it revealed a triple-negative breast cancer. And for this type of cancer, the triple-negative breast cancer, they usually receive neoadjuvant chemotherapy. This was her post-neoadjuvant films, and it is difficult to assess for the response in the post-neoadjuvant films, while with a single look on the contrast mammogram, we can surely say that there is complete radiological response. This is another 53-year-old female with pathologically proved, again, triple-negative breast cancer, and she had an intensely enhancing mass and axillary lymph nodes, matted axillary lymph nodes. This was the time signal intensity curve, which showed a washout curve. She was also a candidate for neoadjuvant, and this was the examination after receiving neoadjuvant chemotherapy. There was complete radiological response. This was the MEP images in the pre-neoadjuvant setting, and this was the MEP images in the post-neoadjuvant setting. Now we're going to discuss the PET mammography. Positron emission mammography, or what we call PEM. PEM is a specialized application of PET to visualize breast tissue metabolic changes with a much higher spatial resolution, thus allowing the visualization of smaller tumors. As tumor cells proliferate and grow, specific metabolic pathways are activated to provide oxygen, glucose, and other nutrients, which are essential for the growth of cancer cells. One of these pathways is the anaerobic metabolism. The glucose is uptaken by the cells by the glucose transfer enzyme, and inside the cell, it becomes subjected to the hexokinase, which changes it into glucose 6-phosphate, which undergoes glycolysis in the anaerobic pathway. If we label this glucose and it becomes the 18F-FDG, it is also uptaken by the cells using the glucose transfer enzyme. Inside the cells, it is also subjected to the hexokinase, which changes it into 18F-FDG phosphate. But this FDG phosphate does not undergo glycolysis, and it becomes trapped inside the cell, thus allowing or giving us enough time to image the radiotracer while still within the cell. The technique of PEM is exactly like the mammogram, where the patients are imaged in the upright position, but what's different is the type of detector and the type of energy that uses the films. The breast is gently stabilized between clear compression plates, and there are two opposing PET detectors that move in a linear manner within the compression paddles to scan the breast for approximately 10 minutes. The images are taken in the CC, the mediolateral oblique, and the extended axillary view, by which we can see the axillary lymph node. The PIM images are displaced as a 12-slice tomographic planes, and the slice thickness is equal to the compressed breast thickness divided by 12. We can either image the images in the grayscale, or we can see them in a color-coded scale. And for MS assessment, we do a qualitative and a quantitative assessment. The qualitative is similar to MRI, where we divide lesions into those which uptake and those which do not uptake the radiotracer. Then we assess the intensity of uptake, the homogeneity. We describe the shape of the lesions, the margins, and associated findings. For the quantitative assessment, it is similar to PET, where we measure the PUV value, which is corresponding to the SUV value, and we also measure the lesion to background value, which is called the LTP. The uptake correlates with the increasing tumor grade. It also increases in triple-negative breast cancer, and it decreases in lobular cancers and low-grade DCIS. This is a screening mammogram of a 55-year-old female. She had a focal asymmetry in the left breast, she was sent for a targeted ultrasound examination, which revealed the right upper outer quadrant irregular hypoechoic mass lesion. Unfortunately, during screening the left side, we also saw a left upper outer quadrant mass lesion, tiny mass lesion. This was the contrast mammogram of the patient, and only the lesion on the right side showed intense contrast uptake, but there was an unexplained skin dimpling on the left side. PEM was requested, and on the right side, she had an intense radiotracer uptake with a PVUV value of 2.9, while on the left side, there was a faintly enhancing nodule with a PUV value of 0.1. When measuring the lesion to background activity, it was 6 on the right side and 1.1 on the left side. Biopsy from both sides was performed, and the right-sided lesion was an invasive duct carcinoma grade 3, while the left-sided lesion was an invasive lobular carcinoma, and that's why we find a great difference in the contrast uptake between both lesions. In PEM, we use FDA-approved radiopharmaceuticals and imaging devices. The main proposed indications include enhanced lesion characterization, preoperative staging. We use it to assess the response to neoadjuvant chemotherapy in the post-breast cancer surveillance, and for screening women for women with dense breast, and for metastasis of unknown origin. And 3 of these points are under research in Bahia Hospital. This is a 40-year-old female with a palpable right breast mass lesion. She had a global asymmetry of the right breast, and on complementary ultrasound examination, there was an underlying malignant lesion, and we suspected that it was a multifocal lesion. This was the contrast mammogram, which revealed 2 adjacent mass lesions within the right breast. And this was the PEM, which added even more lesions to the contrast mammogram with a much wider extension than the contrast mammography. This was another 61-year-old female with edema of the right breast. She performed an MRI somewhere outside Bahia Hospital, and she was told that she had edema pattern with pathological axillary lymph nodes, and no lesions were identified. Looking at the PEM, we can see a very deeply seated lesion which shows radiotracer uptake, and it was biopsied, and it revealed an invasive duct carcinoma. And by this, I end my lecture. And definitely in the last decade, we have witnessed an intense increase in the volume of breast imaging techniques with the development of new technologies and the upgraded applications of already existing ones. Yet a question still remains: with this rapid pace of new developments, has the field of breast imaging exhausted itself, or should we still await even higher technical evolutions? And thank you.